Good morning students, I will be taking Obs and Gynae for PG GIMS. Today's lecture topic is NEET 2018 Obs and Gynae questions. We'll start with the more important questions first and then we'll discuss the easier ones later. There was one particular question which I think is very important. Sacrocolpopexy is done for which prolapse of which compartment? Now to answer this question you should first understand what are the compartments in which pelvic organ prolapses are divided. Basically, depending on the location of the organ, you classify it into three compartments: anterior, middle or apical, and posterior. Now if you see this diagram, you have this anterior compartment. Oh, sorry. Yeah. That's the anterior compartment, the bladder and the urethra. A prolapse of bladder or urethra through the anterior vaginal wall, this part. This prolapses from here or this prolapses from here. That is called anterior compartment prolapse. Similarly, there's this middle compartment which will include prolapses of uterus, the cervix and vagina. This will descend down through the vagina. That's middle compartment or apical prolapse. And then there's posterior compartment prolapse. There is this pouch of Douglas which is formed by reflections of peritoneum from behind the uterus, visceral peritoneum on the posterior side of the uterus, and then anterior peritoneum over the rectum and parietal peritoneum over the posterior wall of abdomen. So that area is called pouch of Douglas. If bowel loops descend through that pouch of Douglas, if you see this diagram, this is the pouch of Douglas. If bowel loops start descending from here because of lax posterior vaginal wall, it's called enterocele or posterior compartment prolapse. Similarly, if rectum has to prolapse, it will prolapse directly through the posterior vaginal wall. These are posterior compartment prolapses. Prolapses are further classified or graded into various grades depending on how far they are from the introitus. Right. Lower 1/3 of anterior compartment prolapse is called urethrocoele. The upper 2/3 is called cystocele. Upper 2/3 will be further classified into 4 grades. Remember, first 3 are on straining and fourth is without straining. First is above the introitus on straining. First grade of cystocele is when the bladder with the anterior vaginal wall has descended below but has still not reached the introitus. And this is on straining. When on straining it reaches the introitus, it is grade 2. Similarly, on straining, if the bladder bulges outside the vagina and through the introitus, you see anterior vaginal wall bulge. It is called grade 3, outside the vagina. And 4 is outside the vagina at all times without straining. Similarly, middle compartment is graded into uterovaginal or uterocervical prolapse. Uterus, cervix or the uterus with the vagina prolapses up to the introitus or beyond the introitus. Depending on that, you will classify into grades 1, 2 and 3. And fourth is when the entire uterus has come down outside the vagina, outside the introitus, the entire uterus with the fundus, so that you feel the fundus outside the introitus. You can feel the fundus of the uterus in the prolapsed organ. That is procedentia. Coming to posterior compartment prolapses can be classified variously. One way is to classify the upper 1/3 as enterocele and the lower parts will be called rectocele. If it is very low, just the perineum has prolapsed, it is called lax perineum. Management of prolapses is of two kinds: non-surgical and surgical. Now remember, surgical is the definitive management of prolapse most of the times. Non-surgical will be done only when you don't want to do a surgical, the patient is refusing a surgical management. Like in a female, and other point is it can be done only for mild to moderate, it is going to be helpful only in mild to moderate prolapses. If you have severe degree of prolapse with decubitus ulceration, non-surgical therapy will not be the definitive management definitely. So only for mild to moderate prolapses, first degree or second degree prolapses, you will think of non-surgical managements, that it will have any benefit. And there are certain women who have medical comorbidities. In these women, you don't want to do a surgery because that will be those patients are high risk cases. In them, we can opt for non-surgical managements. Then there are certain patients who do not want a surgery. For them also, non-surgical therapy is a management option. The other point is you have to explain to them that this is not going to correct the abnormality completely. Like if she has a second degree prolapse, a non-surgical therapy will only delay its progression to third degree. It will not correct the second degree prolapse and make it first degree or 0. Understood? It will not, if an organ has descended, non-surgical therapy will only prevent progression of its further descent. It will not push the organ up on its own, right? So non-surgical therapy prevents worsening, decreases severity of symptoms, increases strength of pelvic floor muscles, and avoids or delays any surgical intervention, does not actually correct the condition. The measures which you use are, first three are correction of the predisposing factors, weight reduction, lifestyle modification, control of diabetes. Now you should know that obesity, diabetes and smoking, all these are risk factors for occurrence of prolapse or worsening of prolapse. So you will first ask them to modify these. Then there's an exercise called Kegel's exercise, which is done by tightening the pelvic floor muscles. It strengthens the pelvic floor muscles and might delay progression of prolapse. Then there's, ring pessaries. Ring pessaries generally are used in old women who cannot be operated on and they have a large symptomatic prolapse. So ring pessary is a ring-like structure which is placed in the upper part of vagina to hold the pelvic organs above the ring pessary. Splinting of rectocele. Somebody who strains at stool and has rectocele will have further worsening of rectocele with each straining. So what you do is, suppose this is your vagina, the patient's vagina, and that's the rectocele descending from here. And every time she strains at stool, this further descends downwards. So what you do is you ask the patient to keep fingers over here, over the posterior wall of vagina while she is straining at stool. So that will prevent further bulge of rectocele. These are the non-surgical measures that we use. Coming to the surgical management options, the actual question which was asked here, surgical management options are divided compartment-wise. You have procedures for anterior compartment, for apical compartment and for posterior compartment. And when there is a combined prolapse, usually when there is weakness of the pelvic floor muscles, the pelvic floor structures or the supports of uterus, it is not of a single compartment. It is mostly an anterior prolapse combined with apical or all the three compartments prolapse. So most of the times the surgical options have to be a combined approach for all the compartments. For understanding purpose, we divide it into three compartments and the procedures are also divided into three compartments, so you know which procedure is for which compartment. Apart from that, for each compartment you have native tissue repair and then you have mesh plasty. Native tissue repair is whatever structures you're left with, whatever strong structures you're left with, you will stitch them together and this will push the pelvic organs up. The other is mesh plasty. At the interface, you will put a mesh. In the body, there will be inflammatory reactions to the mesh, there will be fibrosis around the mesh and there will be strengthening of the structure. That's the principle of mesh plasty. Now, apical prolapses. For apical prolapses, you have certain native tissue repair methods. There is this. Now, the names are only important. You're not expected to know what is done in these procedures. Like they just asked you sacrocolpopexy is done for which compartment. They didn't ask you what is done or what kind of mesh is used in sacrocolpopexy. So you have to have an idea which procedure is done for which compartment basically. Mactal scaldoplasty, ileococcygis fixation, sacrospinous ligament fixation and uterosacral ligament fixation. These are all for apical prolapses, the prolapse of uterus, cervix or vagina. Then mesh plasty, sacrocolpopexy. Now sacrocolpopexy, as the name suggests, see if this is your sacrum and that's the vagina which is descended down. What is done in sacrocolpopexy is there's a mesh. I stitch one end of the mesh at the posterior vaginal wall. A broad part of mesh is stitched here to the posterior vaginal wall, upper posterior vaginal wall definitely, and then the other end of the mesh is stitched to the anterior longitudinal ligaments over the sacrum. This is sacrocolpopexy and this procedure is done abdominally, transabdominally. It can be done open or laparoscopically, right? This mesh plasty which is done abdominally for apical prolapses is the gold standard procedure for apical prolapse these days. Then coming to anterior compartment. Now anterior compartment prolapse, if you remember the diagram, it is a prolapse of the bladder and the urethra through the vagina. Now what I want you to understand is correction of anterior and posterior compartment prolapses are usually done vaginally. If there is only anterior compartment prolapse or if there is only posterior compartment prolapse, you will do a procedure vaginally more often. The native tissue repair done for anterior colporrhaphy is called, for anterior compartment prolapse is called anterior colporrhaphy. You can also place a mesh vaginally between the, see, if this is your bladder and that's the anterior vaginal wall and this is your introitus and they are bulging, already bulging. What we do in meshplasty, transvaginal mesh, is we place a mesh at the interface of bladder and the vagina to strengthen the structure and push it up. Now they say transvaginal mesh is associated with better anatomic support, but it does not improve the quality of life parameters. So the outcome of both anterior colporrhaphy, native tissue repair and meshplasty is the same. The quality of life parameters are not improved if you use a mesh. That's why we always prefer only native tissue repair for anterior compartment prolapse. Right, meshplasty, transvaginal mesh is not very recommended because you don't want to put an additional structure if it does not have any quality of life improvements or the outcome is not improved. For posterior compartment repair, the native tissue repair which we do is posterior colporrhaphy. You can do it with or without levator plication. Levator plication is suturing together of two sides of levator muscles, levator ani muscles. Like if you are operating on the perineum, these are the levator muscles of two sides. What we do is we take stitches across them so that they are approximated and strengthened a little. That is levator plication. This is native tissue repair. Apart from that, transvaginal mesh can also be placed behind the posterior vagina, between the rectum and the vagina. But they have seen evidence suggests that evidence does not support the use of any grafts at the time of posterior vaginal wall repair. What was seen was there was more exposure of the mesh. If you place it in the posterior vaginal wall, there is more infections and fistula formation associated with transvaginal mesh for the posterior compartment, placed for a posterior compartment prolapse. So this is not recommended. So basically what you need to remember is that only meshplasty which is recommended for pelvic organ prolapse is abdominal meshplasty. If the question says transvaginal meshplasty, it is not one of the recommended procedures. Abdominal meshplasty or sacrocolpopexy is the gold standard or apical procedure for apical repairs, while transvaginal meshplasty is currently not recommended for any kind of prolapse. So your answer here is sacrocolpopexy is done for apical prolapses. Now coming to another important question, action of progesterone only pills are all except. Now you have multiple hormonal contraceptives. You have oral, injectable and even in the form of intrauterine devices. All of them contain either estrogen plus progesterone or progesterone alone. So to understand the mechanism of all of them are not completely similar. They're somewhat similar, but they differ because of the doses and the contents, differ according to the doses and the contents they have. Right. So you have to know what each of these hormonal contraceptives contain and how much they contain and what's the mechanism of action. Now, they can be broadly classified. Hormonal contraception, we are only talking about hormonal contraceptions which contain E plus P, estrogen plus progesterone or only progesterone. Short acting ones and long acting ones. The short acting ones are orally given, combined OC pills and progesterone only pills. Then there are long acting ones, injectables, implants and progesterone IUD. Now between these two you have to remember that combined OC pills are given cyclically. You give them for 21 or 24 days depending on the dosage and you give a 1 week gap, while progesterone only pills are to be taken daily without any gap. Now to give you a rough idea of how much dose, how much hormone is present in each of these drugs, I've drawn this table. COC is combined OC pills. It has estrogen in the range of 20 to 50 micrograms, while levonorgestrel or the progesterone component is in the range of 100 to 250 micrograms. While when you talk of mini pill has it is called mini pill because it has a very small dose of progesterone. The progesterone dose here is 30 micrograms. Right, now this is 0.5 to 1/3, 0.3 of the dose of progesterone and combined OC pills. What I'm trying to tell you is that mini pill not only does not have estrogen, it also has a very low dose of progesterone. Then coming to progesterone injectables. Progesterone injectables, an example is depot medroxyprogesterone acetate, which is 150 mg and it is given repeated at every 3 months. Now suppose you have this 150 milligram dose for 3 months. That means in 1 month, if theoretically you assume that the entire 150 mg is used in the body and it is equally divided in the 3 months. So for 1 month, the drug that you will have available is 50 mg. Right, this is very theoretic, it is not given in the books. I am trying to tell you this so that you understand how the mechanism of action of progesterone injectables and mini pill differ. Both of them contain progesterone, but the mechanism differs because the dosage of progesterone is different in them. So you have to understand that progesterone injectables are very high dose progesterones. 150 mg for 3 months, for 1 month you have 50 mg for 1 day. If you calculate, it is going to be around 1.2 mg, 50 by 30. Right, so it is slightly more than 1 mg, while the dose of progesterone in combined OC pills and mini pill is in micrograms. So these are high dose progesterone injectables are high dose progesterones. Then as combined injectables, the daily drug eluted in these is similar to or even lower than combined OC pills. So the mechanism of action of combined OC pills and the combined injectables are similar. Then coming to progesterone IUD. Each IUD contains levonorgestrel IUD, which is also called Mirena, contains 52 milligrams of levonorgestrel and elutes 20 microgram daily. This is similar to the dose of mini pill. So the hormonal action will be similar to mini pill. Apart from that, it will also have the foreign body effect of intrauterine device. Now coming to progesterone implants, you have 3 kinds of implants which are there in the books. Norplant, Zedel and Implanon. Norplant, Zedel contain levonorgestrel, while Implanon contains 3-ketodesogestrel, which is also called etonorgestrel. The dosage is 216 mg, 150 mg and 68 mg. What is important here is they are used for 5 years and 3 years. In the first month, the amount of progesterone which is released is higher, 85 microgram, 100 microgram, 60 to 67 microgram per day. While after 2 years, the amount of progesterone which will be released into blood daily is 30 microgram. Now, if you remember, this is similar to the dose of progesterone in mini pill. So the mechanism of action after 2 years of implants is similar to the mechanism of action of mini pills. Now, after all this, let us try to figure out what the mechanism of actions are. Now, before that, I'll tell you what are the 3 mechanisms of actions of all hormonal contraceptives. One is cessation of ovulation. The hormonal contraception, like if I am giving E plus P, estrogen plus progesterone, they have a negative feedback effect on the hypothalamus and the pituitary, and they cause decrease in follicle stimulating hormone and LH secretion. So you have decreased FSH, LH secretion, you require FSH for stimulation of follicles in the ovary and you require LH for final ovulation in the ovary. These things will be inhibited if FSH and LH are lowered because of presence of E and P in the body constantly. So when you give E plus P constantly, there is feedback decrease in FSH, LH and there is an ovulation. That is one important mechanism of action. The other is, this mechanism of action is by both estrogen and progesterone. So estrogen basically has an effect on the hypothalamus and pituitary. Its role at the end organ, at the level of endometrium and the cervix are minimal. At the endometrium, the main hormone to have a role is progesterone. Progesterone acts on the endometrium and causes endometrial atrophy, or you can also call it endometrial decidualization. Right. Then the third action is thick cervical mucus. This is also an action of progesterone. So as I said, estrogen does not have much end organ effect, it does not have much effect on the endometrium. It doesn't cause proliferation of endometrium. The small dose of estrogen which we use, this dose is very less compared to the physiologic range of estrogen present in a female's blood. So this small dose of estrogen is only able to have a negative feedback effect and decrease FSH, LH. By its constant presence, it decreases the cycling which is present, which is responsible for ovulation. FSH, LH become stabilize at a constant low level. So an ovulation results. This is because of estrogen and also because of progesterone. Both play a role and both have negative feedback effects on HNP. Apart from that, progesterone alone has the effect of endometrial atrophy and thickening of cervical mucus. Estrogen does not have much end organ effects. Now coming to the mechanism of action of each of the hormones. Combined OC pills and combined injectables have all three effects: inhibition of ovulation, endometrial atrophy and thick cervical mucus. While progesterone only pill, because it has very low dose progesterone, it does not inhibit ovulation, while it makes cervical mucus thick, causes endometrial atrophy and makes cervical mucus thick. Then coming to progesterone implants, which are also low dose. For the first 2 years, because the dose is comparatively higher, progesterone can have some negative feedback effect, and for the first 2 years you can have inconsistent anovulation. But later, and even in the first 2 years, the most consistent effects are endometrial atrophy and thick cervical mucus, responsible for contraception effect. Then coming to progesterone injectables, which I told you earlier, are high dose progesterones. That's why they have this effect of anovulation, endometrial atrophy as well as thickening of cervical mucus. Then Progestasert, in some women, they might inhibit ovulation. So all these progesterone drugs might sometimes inhibit ovulation. This very rarely. Progestasert also inconsistently will inhibit ovulation, but the main action of all these progesterone drugs is endometrial atrophy and thickening of cervical mucus. Progesterone injectables, since they are high dose progesterones, definitely inhibit ovulation. Now your question says mechanism of action of progesterone only pills are all except. Okay, I didn't write except here. The question is are all except. Suppression of ovulation, completely suppression of ovulation sometimes. Even if you didn't know anything about the topic, these two answers, these two options are contradictory. So one of them has to be the answer. Another clue I'll give you for answering in exams, nothing is absolute in MCQs or in the medical field, nothing is absolute. If an option says so and so drugs always treats this condition, that is a wrong option. So and so symptom is always present in this disease, that is again a wrong option. So absolute options are never correct. There is no absolute in medical field. Someone like another example would be so and so infection always leads to this disease. That is also not true. The same infection might lead to very severe disease in some person and might not affect the other. Another person might not be affected by the disease at all. So there's no absolute in medicine. Any absolute option is usually the answer if they're asking, or any absolute option is usually incorrect. Suppresses ovulation completely. Nothing suppresses or nothing does anything completely in medicine. Apart from that, from all the theory that I've taught you, you know that thickening of cervical mucus is an action out of phase endometrium or endometrial atrophy. Out of phase endometrium means that at the time of ovulation, the endometrium is receptive to implantation of the embryo. If you give progesterone throughout the cycle, it causes endometrial atrophy and decidualization, and the endometrium is out of phase for implantation at the time of ovulation. So this is also a mechanism of action. Suppresses ovulation. Sometimes these dicey options, sometimes may not, are usually correct because everything may do something. I don't want to be vague. I just want to give you a tip that absolute answers are never correct. So your answer here is mechanism of action of progesterone only pills is all except it does not suppress ovulation completely. Which of the following is an indication of pre-implantation genetic diagnosis? Now I'm sure most of you have marked this answer incorrectly. It's a very important question. It touches two important topics. One is assisted reproductive techniques and the other is prenatal diagnosis. Right. The technique by which you do pre-implantation genetic diagnosis is artificial or assisted reproductive techniques. The indication of pre-implantation genetic diagnosis is similar to prenatal diagnosis. Then the question basically aims to ask you the difference between PGD and PGS, pre-implantation genetic diagnosis, sorry I've written D here, pre-implantation genetic diagnosis and pre-implantation genetic screening. The question basically is only the difference between screening and diagnosis because all other options are screening options and one of them is diagnosis options. Now let us see what PGD is. As I told you, it is an ART method done actually for prenatal diagnosis. Now suppose there is a couple both of them are recessive, both of them are carriers of a recessive condition like cystic fibrosis. So this is the father who's a carrier, that's the carrier gene, and that's the mother who's a carrier. So you have a 25% risk of an affected baby. They want to know whether the baby is affected or not. So one option for them is to conceive naturally, and then at 11 weeks you do chorionic villus sampling, you do genetic testing, and you tell them whether the baby is affected or not. Now if the baby is affected, they'll have to abort the baby at 11 weeks. So that stress they have to undergo of conceiving and then aborting an affected baby. This can be overcome if you do pre-implantation genetic diagnosis. What I'll do is, I'll do an IVF, even if they're not fertile, not infertile. They're not infertile, they're going to conceive naturally, but still I do an artificial reproductive technique because I want to do pre-implantation genetic diagnosis. What I do is, I take the female oocyte, I take the male sperm, I fertilize it in the laboratory, I do in vitro fertilization. Then I get a few embryos. Supposing I have got 4 embryos. On day 3 of fertilization, I have 4 embryos with me from the 4 oocytes which I had. Now what I do is, I take one cell of each of these embryos and I run my genetic tests on them, and I detect which of them has cystic fibrosis, which of them has this double homozygous, which of them is actually affected by cystic fibrosis and which does not have the gene. Out of the 4, the healthiest one, the embryo which does not have cystic fibrosis gene, will be implanted into the mother's uterus, and she will now be sure that she has a baby who's not affected. This is the use of pre-implantation genetic diagnosis. So for this, the only problem is you need ART, it cannot be done with natural conception. So before PGD, the only option such couples with genetic abnormalities had of pre-implantation, they only had the option of prenatal genetic diagnosis, or they could undergo oocyte or sperm donation and adoption. Now with this, you have the option of implanting the healthiest embryo, the embryo which does not have the genetic abnormality. Now coming to PGD, your question, pre-implantation genetic diagnosis. Now you have to remember diagnosis and screening. The basic difference between any diagnosis and any screening is that when you're looking for a particular condition, when you're suspicious of a particular condition, you run tests only for that condition, it is a diagnostic test. And when you're not sure, in genetic diagnosis, basically this is not the diagnosis and screening of PSM, it is the diagnosis of, it is the difference between genetic diagnosis and genetic screening. Genetic diagnosis you do when you know which gene you have to screen, which gene you have to test, which condition you are looking for. While genetic screening is done when you want to know whether the baby has Down syndrome, Patau syndrome, there is no risk factor, or basically there is a in general risk factor for chromosomal abnormalities. You don't know which particular condition you are looking for. That is screening. That's the difference between, be it pre-implantation genetic diagnosis or prenatal diagnosis, or pre-implantation genetic screening and prenatal screening. The difference is when you're looking for a particular disease or when you're not looking for a particular disease. So diagnosis is when you know which condition you are looking for. PGD is an early form of prenatal diagnosis for couples at risk of transmitting a genetic disorder to their children. Genetic methods which we use. The methods for diagnosis and screening will also differ, because here you have to test only one gene, while for screening you have to screen the entire chromosome, or at least the chromosomes which have a high risk of having aneuploidy and affecting the baby. So that's the genetic tests done are also a little different. Genetic methods used here are PCR, FISH, microarray, CGH and karyomapping. This is not karyotyping, karyomapping. Karyotyping will tell you about large chromosomal abnormalities. Karyomapping is a new method of detection of genetic disorders. Now, indications of PGD. If there is a genetic disease in the couples, or they are carriers of genetic diseases, single gene diseases like which are autosomal dominant, recessive, X-linked or Y-linked. Then chromosomal abnormalities. If there's a couple who has recurrent pregnancy loss, you did karyotyping of both the parents, and one of them or both of them were carriers of balanced translocations. These balanced translocations are known to not affect the phenotype of the person, but they affect fertility by increasing the chance of pregnancy losses. In these balanced translocations, what happens, suppose this is 21-14 translocation. You have a part of chromosome translocated between two chromosomes. A part of gene is translocated between two chromosomes, but because it is balanced, it is not affecting the person. It is not affecting the person's phenotype. While at the time of meiosis, what happens? There is loss of, or there is addition of genetic material because of these balanced translocations. So balanced translocation after gametogenesis and fertilization changes into unbalanced translocation, which can cause recurrent pregnancy loss. So if you have history of recurrent pregnancy loss with known balanced chromosomal abnormalities, balanced translocations, then you know which translocation you are looking for in the embryo. Those cases, it will be called pre-implantation genetic diagnosis. Couples in which one of the partners is a carrier of chromosomal rearrangement. Then mitochondrial disorders or complex inherited diseases. HLA antigen, this is another interesting indication of doing PGD. Suppose there's a couple who has an offspring with a condition like thalassemia major or leukemia. A child who needs basically stem cell transplant, and you cannot find a HLA donor for the child. So what you do is you ask the couple to undergo IVF. We will have 4 embryos. We will do HLA typing of all these 4 embryos, and whichever embryo has HLA matched to the offspring, to the alive offspring who needs stem cell transplant, that embryo will be implanted. So that after 9 months you will have stem cells for the living baby who has leukemia. Right, that's another indication. Now coming to PGS, pre-implantation genetic screening. Here we in general screen for aneuploidies like Down syndrome, Patau syndrome, all those things. Now you know that the risk of aneuploidy in the fetus is increased if the mother is elderly or if there is a past history of aneuploidy in the previous pregnancy. So when you don't know which genetic abnormality can be present, which genetic abnormality I'm looking for in the embryo, it is called PGS. So PGS applies to it. The technology is same. You do IVF, you get embryos and you test the embryos with genetic testings. It is used in older women, those with history of recurrent miscarriage, where you tested for translocations but they did not have any translocations. And in women with repeated unexplained IVF failure. So these are the indications for doing pre-implantation genetic screening. The tests you do are FISH and CGH. With FISH, you can identify aneuploidies of XY 13, 16, 18, 21 and 22, while CGH, comparative genome hybridization, will screen the entire chromosome. But this takes time. CGH is a longer procedure. So your answer here, which of the following is an indication of PGD? Advanced age is an indication of pre-implantation genetic screening. Single gene disorder is your answer because aneuploidy risk again is an indication for screening and recurrent abortions for screening. I hope that makes the answer clear. Right. See, because this is only one specific thing that they're talking about. When they say aneuploidy risk, they have not specified which aneuploidy the couple wants to rule out. When they specify, it is PGD. When they don't specify, it is PGS screening. Now coming to another question on artificial reproductive techniques, ART is most commonly associated with which kind of twins? Now there are 2 kinds of twins. Basically based on the number of zygotes they are derived from. There is monozygotic and then there is dizygotic. Monozygotic is when you have a single oocyte fertilized by a single spermatocyte forming into a single zygote, which then forms a single embryo, which at various stages of development may divide to give 2 fetuses. This is monozygotic. These 2 fetuses will have completely similar genetic makeup. These 2 fetuses will have completely similar genetic makeup. This is monozygotic twinning. The sex of these 2 fetuses will also be same. Then dizygotic twinning is when you have 2 oocytes fertilized by 2 different spermatocytes. At the same time, in the same cycle, the oocytes may be derived from the same ovary or from 2 different ovaries. Basically, in the uterus, you have 2 two fetuses of different genetic makeup, because these are two different oocytes, different spermatocytes. The genetic makeup of these two fetuses is completely different. It is just like two siblings temporarily growing at the same time in the mother. So these are dizygotic twins. Dizygotic twins can be of the same sex, can be of different sex, but monozygotic will always be of the same sex. Now, depending on what time, at what period of gestation and at what stage of development this embryo divides, monozygotic twins can be further classified into various types. Dichorionic diamniotic is when you have two different placentas and two different sacs. So there's no connection between them. The placentas are separate, the amniotic sacs are separate. This is the lowest risk monozygotic twin pregnancy. When the embryo separates before 3 days, up to 3 days after fertilization, it forms diamniotic dichorionic. Then monochorionic diamniotic is when you have a single placenta and then you have two different sacs. This is monochorionic diamniotic, MCDA. Then you have monochorionic monoamniotic, a single large placenta and a single sac in which you have two babies. This is monochorionic monoamniotic. And then this will be when the division takes place between day 8 to day 13. Later, if division takes place, you have various degrees of conjoined twins. If the division is further after day 15, you can have a twin with multiple organs, like you have dicephalous twin or you have a twin with multiple arms. This is very rare. Now, this dizygotic twinning can be affected by a number of factors: race, heredity, maternal age. As age increases, the risk of having twin pregnancy increases. Increased parity, nutrition, taller, heavier women have higher risk of having multiple pregnancies. Conception immediately after stopping a COC. And infertility therapy, any kind of infertility therapy. Infertility therapy can be simple medical ovulation induction, or it can be an artificial reproductive technique. When I do ovulation induction, I am giving her drugs to increase FSH, LH and to cause ovulation. So sometimes the female already is ovulating and you give an ovulation induction drug, it actually causes multifollicular development. So you have more than one oocyte forming, and because of this drug, since you have more than one oocyte, there can be more than one oocyte getting fertilized and you have high risk of twin pregnancy. In ART, as I said, what we do is, we do in vitro fertilization in the lab. We form a few embryos in the lab and we implant these embryos. If the embryo is very healthy, the couple is healthy, we generally aim to implant only one embryo. But in such cases, most of the couples are not very healthy and the embryos that you obtain are not of optimum quality. So we have to implant 2 or 3 embryos, hoping that at least one will implant. Sometimes what happens is all the 2 or all the 3 embryos will implant and you will have multiple pregnancy. That's why any kind of infertility therapy increases the risk of twin or multiple pregnancy. Then previous dizygotic twinning. These are all the risk factors for dizygotic twinning. Now if you come to, this is monozygote, factors affecting monozygotic twinning. If you come to monozygotic twinning, it is a simple chance factor. There was an embryo which somehow got divided into 2 parts and then twins started developing. So it is rather a chance factor and it is not affected by many, it is not dependent on any risk factors. That said, there is one more thing. In ART, there is slight increase in risk of monozygotic twinning as well. What happens is, you are manipulating the embryos in lab. You are picking these embryos and you are implanting into the mother. There is some kind of injury, there might be an injury to these embryos which may lead to division of these embryos inside the uterus, and this may result in twinning. That's why ART also does increase the risk of monozygotic twinning, but it is proved that the risk of dizygotic twinning definitely increases. So if it increases the risk of twinning, it mainly increases the risk of dizygotic twinning more than monozygotic twinning. Right, so ART is most commonly associated with, the answer here is dizygotic twinning. The other options are all monozygotics. It does increase the risk of monozygotic twinning, but the risk is very low. The best period of gestation for ultrasonography determination of chorionicity. Now if you see this table, there are these kinds of zygotic. We are talking about monozygotic twins. The diagnosis of a monochorionic monoamniotic twin is straightforward. You have a single large placenta, you have one sac and two babies. Basically, you don't have any intervening membrane in them, and you know it is monochorionic monoamniotic. The differentiation between dichorionic and monochorionic is difficult. In both the pregnancies, you have placenta. Here you have two placentas and two amniotic sacs. And in monochorionic, you have a single placenta and two amniotic sacs. So this, to differentiate between these two is difficult because both of them have an intervening membrane. So you have to see, two things you have to see here is the distance between the thickness of this intertwining membrane and the lambda sign. If you see, this is the lambda sign. There's a gap between the two placentas, and in monochorionic diamniotic twins you have this sign called T sign. This is seen earliest, this is seen best earlier in pregnancy. When the fetus grows, this will be obliterated and it will be different, and the membrane will be further thinned, and it will be difficult to differentiate between dichorionic and monochorionic pregnancies. So the best time to determine chorionicity is, in this question, is definitely 8 to 12 weeks. Yeah, the answer here is 8 to 12 weeks. Basically, according to the guidelines, between 10 to 13 plus 6 weeks in twin pregnancy, you do a scan for nuchal translucency, you do it for chorionicity and for dating the pregnancy. So for all these three indications, you have to do a scan in twin pregnancy at 10 to 13 weeks for nuchal translucency, chorionicity and dating the pregnancy. Idle time is 10 to 13 weeks. In the question, the only option valid is 8 to 12 weeks here. And you see NT and dating as well during the pregnancy. The signs that I told you already are lambda sign. This is lambda. This means dichorionic, diamniotic. Both of them are diamniotic. To differentiate between monoamniotic and diamniotic is easier, but to differentiate between dichorionic and monochorionic is difficult. So this is the lambda sign of dichorionic, and that's the T sign of monochorionic twin pregnancy. So your answer is 8 to 12 weeks. Now coming to the next question, this is another question on twin pregnancy. What is superfecundation? There are two terms, superfecundation here, right? Superfecundation, and there is superfetation. Both of these things principally are similar. It is two different oocytes fertilized by two different spermatocytes at two different acts of coitus. The difference between fecundation and fetation is only of the cycle. If it is in the same cycle, it is called superfecundation, and if it is in two different cycles, consecutive cycles, it is superfetation. So let's see the definition. Superfecundation refers to fertilization of two ova within the same menstrual cycle. Like 2-3 days, there was a gap of 2-3 days. First ovum got fertilized 2-3 days back, and then a second ovum got released, which got fertilized subsequently in the same cycle. Right. And in superfetation, you have a difference of one menstrual cycle. There was ovulation and fertilization in one cycle, the next cycle she continued to ovulate. Now that is not seen in human beings. Once she conceives, a female hardly ever ovulates. This is seen in horses, rather mares. What happens is they continue to ovulate even after conception, and then there is a possibility of superfetation. In the second cycle, she can be fertilized at the second act of coitus. Right, so superfetation is not known to occur spontaneously in humans. Here your answer is it A? Fertilization of two ova within the same menstrual cycle at separate acts of coitus. That's correct. What is B? Two ova, consecutive menstrual cycles. This is superfetation. And one ovum by two different spermatozoa in separate acts of coitus. Now that I don't know if it occurs. One ovum, if it has got fertilized, it will not get fertilized again. Fertilization of two ova by two spermatozoa at the same act of coitus will result in dizygotic twinning. So your answer is A. Coming to this next question, quadruple screening. This is another question on prenatal screening. So you can realize now that this year's NEET paper concentrated on twin gestation, artificial reproductive techniques and prenatal diagnosis. Quadruple screening is done at quadruple screening is done at what weeks of gestation? Any screening tests that we do it in before 20 weeks of gestation. This you have to remember, because after 20 weeks of gestation, to know whether the baby has Down syndrome or not is not going to have any effect unless you're going to do an intrauterine procedure and correction of the abnormality. So before, we mainly aim to know, to have prenatal diagnosis before 20 weeks, because if there is a need for abortion, we'll abort the baby before 20 weeks. So all the tests are basically done so that you get the results before 20 weeks. Now these are genetic tests. To confirm, you always have to do genetic tests. Genetic tests like karyotyping or CVS may take up to 7 days. Karyotyping may even take 10 to 14 days. Right, so you should have this margin to be able to carry out abortion. That's why all your tests should ideally be done up to 18 weeks. Now in this, we divide the prenatal screenings into first trimester screening and second trimester screening. The first trimester screenings are done with the NT scan, as I told you in the previous answer, at 10 to 13 plus 6 weeks. This is the time you do first trimester screening, not before this. And the second trimester screenings are usually done at 15 to 18 weeks. Now what are these screenings? First trimester screening is nuchal translucency plus dual markers, which are PA, PP and beta HCG. This is done at 10 to 13 plus 6 weeks. The detection rate of Down syndrome is 82 to 87% with a false positive rate of 5%. While triple screen, which includes AFP, beta HCG and unconjugated estriol, it is done at 15 to 20 weeks. It can be done from 15 to 22 weeks, but in India we do it from 15 to 18 weeks only, because we want the result by up to 19 weeks so that we can decide on abortion. Similarly, quadruple screen can be done up to 15 to 22 weeks, but it is done at 15 to 18 weeks only. There is no point in having a result at 20 weeks when you cannot do anything. There's no point in having a result at 20 weeks when you cannot do anything with the result. So you do all the screenings, the second trimester screenings before 18 weeks. So 15 to 18 weeks is your answer. Penta screen is a new screen. I thought I would tell you. Apart from the markers of quadruple screen, AFP, beta HCG, UE3 and dimeric inhibin A, apart from that we also use hyperglycosylated HCG, which is also called invasive trophoblast antigen. This is a new marker which is used in Penta screen, again done at 15 to 22 weeks, still in its experimental phases. So your answer here is 15 to 18 weeks. All of the following can cause secondary PPH except. Now there are two forms of this question. Some say this option had placental polyp, or this option was polyp alone. Now we will see what the answer will be in both the scenarios. Now what is secondary PPH? Secondary PPH is bleeding into genital tract after 24 hours of delivery up to 12 weeks from delivery. There are various causes. The most important ones are retained products and infection, endometritis. These are two important causes of secondary PPH. So if you had a rough idea of these two things, you could have answered this. Endometritis, definitely. Placental polyp. Placental polyp is when a part of placenta is retained in the uterus. It forms a polyp after some time, polyp-like structure after some time. This can get infected, eroded and can cause recurrent secondary PPH. Retained bits of placenta. So these three definitely cause secondary PPH, while placenta previa rather causes antepartum hemorrhage and primary PPH. It is not an important cause of secondary PPH. The causes of secondary PPH which have been mentioned in books are abnormalities of placentation, that is placenta accreta, increta or adherent placentas. Idiopathic subinvolution, the uterus is not involuted properly, you can have trickling of blood. Retained placental tissue. William says retained products may undergo necrosis with fibrin deposition and may form so-called placental polyp. As this polyp detaches gradually, this may lead to brisk hemorrhage. So this is a cause of secondary PPH. Endometritis, infection of the endometrium, infection and dehiscence, and even dehiscence of caesarean scar or endomyometritis, any kind of infection can cause secondary PPH. Apart from that, as I said, retained placenta, placenta accreta, increta, percreta, all these things can also result in secondary PPH. Congenital coagulopathies will be another reason, post-cesarean wound dehiscence, pre-existing uterine pathology, a vascular malformation, a submucous fibroid. Now pre-existing uterine pathologies can come into play and then they can cause bleeding up to 12 weeks of delivery. Rupture of vulval hematoma. If there was a vulval hematoma at the time of delivery and then it ruptures later, it can cause secondary PPH. So your answer here is simply placenta previa. Now if the option did not have placental, if there was only polyp, then I would mark polyp, because gynecologic polyp, the endometrial and mucosal polyp, will hardly ever cause secondary PPH. If the question does not mention placental polyp, please mark polyp as the answer, because polyp does not cause secondary PPH, it causes menorrhagia or the gynecologic bleeding, intermenstrual bleeding. Then placenta previa may cause, because placenta previa is associated with placenta accretas in most of the cases. So by exclusion here I would mark polyp. But I am sure the question must have been placental polyp, because Williams clearly states that placental polyp is a cause of secondary PPH. So they wanted to ask you about placental polyp only, most likely. Most common cause of palsy in postpartum period. Now by common sense also I would mark foot drop here, because if delivery has to occur, it affects the nerves going down from there, the lumbosacral plexus of nerves, and one of the nerves which can be involved here is only the nerve which, the paralysis of which can cause foot drop. Wrist drop, median nerve drop, facial nerve palsy, these are unlikely. Now what happens is, the maternal obstetric paralysis as such is very rare, but sometimes lumbosacral trunk compression at the pelvic brim may have certain manifestations. The other thing is delivery in lithotomy position. The patient is lying in lithotomy position, the legs are at the stirrups. These stirrups can injure the common peroneal nerve and can cause common peroneal nerve palsy, which again results in foot drop. Understood? So your answer here is foot drop is the commonest, your answer here is foot drop is the commonest palsy in the postpartum period. Williams also mentions that though paralysis is very rare, it is only foot drop which can be seen in certain cases. Serum levels of which of the following is least affected by pregnancy? Physiologic changes in pregnancy is a very important topic. You should know it in and out, even the percentages of changes which occur, how much something changes in pregnancy. This question is a relatively easier one. Which of the following is least affected in pregnancy, which is not affected in pregnancy? TSH. Now if you note, the structures of TSH, HCG, LH, FSH are somewhat similar. They have similar alpha units, alpha subunits are similar. That's why when you do a urine pregnancy test, you do a beta HCG test, because the alpha component of all these four are homologous. Pregnancy is associated with very high levels of HCG. So these high levels of HCG have some TSH-like effect. So if they have this TSH-like effect on the thyroid, they will cause increased release of thyroid hormones. Now these increased thyroid hormones will in turn cause decreased TSH. There will be a decrease in TSH. So this is a consistent feature of pregnancy. The the TSH decreases because of the rising HCG, and the peak of HCG in pregnancy is at around 10 to 11 weeks. Similarly, the lowest level of TSH in pregnancy is also found at 10 to 11 weeks. So these have reciprocal inverse relations. TSH levels are lower compared to non-pregnant state. Even the ranges have to be altered. The range of TSH in the first trimester is 0.1 to 2.5. If you have a patient in first trimester who has a TSH of 3.5, you have to start, and she's T3, T4 are normal, you have to start her on thyroxine, because this is subclinical hypothyroidism in pregnancy. So the range of TSH in first trimester is 0.1 to 2.5. In second trimester it is 0.2 to 3. Third trimester 0.3 to 3. So basically TSH falls during pregnancy. Then the other point is hepatic synthesis of thyroid binding globulin, TBG, increases. This thyroid binding globulin, as I said, HCG has an action on thyroid. It increases thyroid hormone secretion. Thyroxine secretion increases because of HCG, and liver increases the synthesis of thyroid binding globulin. So whatever T3 you have, a large part of it is getting bound to TBG. So T3 is increasing, the secretion of T3 or T4 rather. T4 is the main hormone here. T4 is definitely increasing, but most of it is getting bound to thyroid binding globulin. That's why total thyroxine and total triiodothyronin, both of the levels will increase. Totals will increase, while levels of free T3, free T4 will be largely unchanged. Understood? So your answer here is free T3 is least affected, free T4 rather is least affected by pregnancy. TSH falls, total T3 rises, total T4 also rises. Question number 11. Which of the following is true regarding peripartum cardiomyopathy? This question was simply on the definition of peripartum cardiomyopathy. Now before seeing the options, we will see the actual definition, the old criteria. There were definitive criteria in the olden times. This has only recently been changed. This can still be asked in your question. So don't be under the impression that this is old. This is relatively older. The newer definitions have come, but the MCQs still can ask this older definition. The definition is development of heart failure within the last month of pregnancy, 1 month before delivery or 5 months after delivery. This is the periodic criteria. Absence of determinable etiology of heart failure. There is no other cause. She was not suffering from any other viral myopathy or cardiomyopathy, or she was not suffering from preeclampsia induced heart failure. In those cases when there is no other etiology of heart failure, you can call it cardiomyopathy. Any heart disease before pregnancy, she did not have any heart disease which was not related to pregnancy, and she did not have any heart disease before pregnancy. Then echocardiographic criteria are LV ejection fraction less than 45%, fractional shortening of less than 30%, and end diastolic dimension, no, that's not shortening, end diastolic dimension of more than 2.7 per meter square of body surface area. Now these are cardiologic definitions. For obstetrics, you just have to remember them. The numbers are 45, less than 45% is the LVEF, less than 30% is fractional shortening, and the dimension is more than 2.7 per meter square of body surface area. These are the criteria for defining peripartum cardiomyopathy. Now according to European Society of Cardiology, the newer definition is a little lenient. You don't have the echocardiographic criteria. The LV may not be dilated. You don't need the dilatation part. The only criteria required here is ejection fraction should be less than 45%. Apart from that, the rest of the things remain same. Time of presentation is 1 month before delivery or 5 months after delivery, and then it is a diagnosis of exclusion when other conditions are not found. Now see the options. Development of heart failure within the last month of pregnancy or within 7 days. It's not 7 days, it is 5 months. Development of heart failure intrapartum. Now intrapartum heart failure can be because of peripartum cardiomyopathy, but that's not the definition of cardiomyopathy, or it is not a very correct option here. Usually seen in women with pre-existing cardiomyopathy, that excludes the diagnosis of peripartum cardiomyopathy. You should not have a pre-existing heart condition. Development of heart failure within the last month, so your answer is D, last month to 5 months after delivery. Most common form of anesthesia given in cesarean section done in a pregnant female with preeclampsia. Now what are the forms of anesthesia that can be given for cesarean section? You can give regional or neuraxial anesthesia. Regional anesthesia or neuraxial anesthesia, or you can give general. We generally prefer for cesarean section a neuraxial anesthesia. Most commonly used is single shot spinal technique. Epidural catheter can also be used. Epidural is basically more commonly used for labor analgesia. You place this epidural catheter and you can adjust the dose of drug through this epidural catheter. This takes a little longer time. For cesareans, what we prefer is spinal anesthesia. If an epidural is already in place for labor analgesia, you can extend it for use in cesarean section as well. Then combined spinal and epidural is also used in some cases. Then there's general anesthesia. The indications of using general anesthesia in cesarean sections are very specific. You cannot always use general anesthesia in cesarean sections. So spinal is most common form of anesthesia used in cesarean section. It can be safely used in patients with preeclampsia. Epidural can be used. Now epidural, since you can adjust the dose, you can keep it for a longer time. So when you are expecting a longer period of surgery, when there's going to be some complication, you are expecting a lot of PPH, or you might need hysterectomy, those cases you will do epidural. You might give epidural. General anesthesia, for emergency cesarean, when you don't have the time to give spinal, like there is a severe fetal distress and there's no time to make the patient sit, get a spinal anesthesia and then lie down. So spinal basically takes a little time, and even to act spinal anesthesia needs some time. While induction in general anesthesia is very fast. So when you need very fast cesarean section, when you have to deliver the baby very fast for the mother's or the baby's health, then you give general anesthesia. So in general, for any elective cesarean section, now it is known that regional anesthesia decreases blood pressure, causes hypotension. Still, it is spinal anesthesia or regional anesthesia is a more controlled anesthesia for the anesthetist. So even in placenta previa or preeclampsia, if it is an elective section, we always prefer spinal anesthesia. If it is an emergency section, you have the option of giving spinal anesthesia. If there is sufficient time to give spinal anesthesia, I will give spinal, but if there is no time, I cannot allow that much time to be wasted for spinal anesthesia, I will ask the anesthetist to give general anesthesia. Otherwise, spinal is the best choice for cesareans. So in certain conditions, when you have to deliver the baby very fast, you give general, otherwise always it is spinal. So your answer here is spinal anesthesia. Umbilical cord contains, now this is more of an anatomy question. Let's see the umbilical cord structure. Umbilical cord at term has two arteries, thick walled arteries, and there is this one thin walled vein, and in between you have Wharton's connective tissue called Wharton's jelly. Outside you have a single layer flattened squamous epithelial lining. So the cord at term normally has two arteries, one vein, and another important thing to remember is there's just one vein. This one vein is the left vein. Left vein is left. This is the mnemonic we used to remember which vein is left. Wharton's jelly is the mucous connective tissue or mucoid connective tissue which is present, and then there is a simple squamous epithelial lining. So your options say umbilical cord contains two veins, it contains two arteries. Left artery is left, actually left vein is left. And then Wharton's jelly, C is also incorrect. The answer here is definitely D. Antihypertensive not used in pregnancy, very simple question. Very straightforward question. You already know the fight is between labetalol and methyl dopa, which is the drug of choice. So labetalol is used, nifedipine is used, hydrolysine is used in emergencies, while atenolol is not used. It has been associated with intrauterine growth restrictions. Now to revise this topic again, let's just brush through the drugs. What's the used first line therapy that you use are methyl dopa, labetalol and nifedipine. Out of methyl dopa and labetalol, till now the books were not clear which is the first line of drug, but RCOG, according to Royal College of Obstetrics and Gynecology, the first line drug is labetalol for long-term control. If you cannot use labetalol, if the patient does not want to use labetalol, then you will use methyl dopa. If there is any contraindication to labetalol, then you will use methyl dopa. Otherwise, your drug of choice is labetalol according to RCOG. So these are the drugs for long-term control. Drug of choice for long-term control according to NICE and RCOG are labetalol. Immediate control for hypertensive crisis, you can use labetalol IV, hydrolysine or nifedipine oral. Second line drugs which was asked earlier in one of the exams are esmolol, nicardipine, labetalol infusion pump may be used, or sodium nitroprusside. Now there has been a lot of controversy over whether sodium nitroprusside should be used in hypertensive crisis or not. There was this question in the past where they asked you whether diazoxide or sodium nitroprusside, which one you will use in hypertensive emergencies. Now some book says because nitroprusside can cause cyanide toxicity of the baby, you will not use. Now see, there is hypertensive crisis in the mother. The mother might die of hypertension if you don't treat. So baby having cyanide toxicity is not the prime concern right now. Right now we need to treat a hypertension. So the sodium nitroprusside definitely is used. If other options are not helpful. If your other drugs have not been able to decrease her BP, you will use sodium nitroprusside. Cyanide toxicity, it only causes after a long usage. Diazoxide is known to cause, diazoxide not so effective as sodium nitroprusside, plus it is known to relax the uterus. Now in a patient in hypertensive crisis, you want her to deliver fast as well. So diazoxide is the drug which is not used, sodium nitroprusside is used. Don't worry about the cyanide toxicity of the fetus, because mother is more important here, and cyanide toxicity will develop only later. Probably you will not require so much nitroprusside which can cause cyanide toxicity of the baby. Basically, I want you to remember that sodium nitroprusside is used in hypertensive crisis in pregnancy. Now, European Society of Cardiology in 2011, in one of its documents also said that the drug of choice of hypertensive crisis in pregnancy is sodium nitroprusside. Drugs to avoid in pregnancy, in general you have to remember these 4 drugs. The most important are angiotensin converting enzyme inhibitors and ARBs, ACE and ARB. Now these decrease renal output, cause oligohydramnios and multiple organ defects in the babies. Atenolol causes fetal growth restriction. Diuretics, now you have to be cautious while using diuretics. Diuretics can be used in pregnancy if they are indicated. Suppose you have pulmonary edema, you're definitely going to use diuretics. But for hypertension, if you're using diuretics, you have to be cautious. So basically this is not contraindicated. You have to know the indication that you're using it for. Don't use diuretics for a simple hypertension in pregnancy. It can cause uteroplacental insufficiency by decreasing maternal blood volume. So your answer here is atenolol. Management of shoulder dystocia. Now one thing that always confuses most of the students is what is fundal pressure and what is suprapubic pressure. That's the uterus and there is this baby inside. If I press here, it is called fundal pressure. If I press here above the pubis, it is called suprapubic pressure. Suprapubic pressure is allowed, fundal pressure is not allowed. This is even recommended for shoulder dystocia, suprapubic pressure. While fundal pressure in modern obstetrics is not allowed anywhere except for cesareans, you can give the anesthetist or someone can give fundal pressure. That's a different thing. You have the abdomen open. Fundal pressure for vaginal delivery is not recommended. So this is not going to be your answer for any question. Flex mother's thighs or abduct mother's thighs or immediate cesarean section. We'll first see the algorithm for management of shoulder dystocia. So you have shoulder dystocia, first thing you do is you call for help, because alone you will not be able to handle. You call midwife, obstetrician, pediatrician, your senior, all those things, you will collect everyone. That is what we do in gynecology. We shout and call everybody. So call for help. And that's important here. The second thing you do is Mac-Roberts maneuver. Flex the female's thighs. These thighs, if you flex the female's thighs over the abdomen, what it does is the pelvis tilts upwards. Now see this diagram. I'm poor at drawing diagrams. That's the pelvic plane and that's your lumbar vertebra. This is lumbar and this is the sacral. This is lumbosacral angle. And that's your pelvis. If I rotate the axis of pelvis, the pelvis is like this. If I rotate it upwards, if I rotate the axis of the pelvis upwards, what happens is this notch, this lumbosacral angle which is there, it reduces and you have flattening of the lumbosacral angle. That is what Mac-Roberts maneuver or flexing the thighs is doing. It is straightening this notch. It does not increases the dimensions of the pelvis. It only straightens the lumbosacral angle and allows the lodged shoulder. What is shoulder dystocia? Shoulder dystocia is when the head is delivered but the shoulder is still behind the pelvic brim. So if there's a shoulder stuck here, this is your lumbosacral angle, that's the pelvic inclination, the head is outside and the shoulder is stuck here. If I straighten this angle, it will be easier to deliver the shoulder. So that is what is done by Mac-Roberts maneuver. When you flex the legs, the angle straightens a little. So this may deliver. Along with this, you will also give suprapubic pressure over the abdomen. Here, your assistant will or you will give suprapubic pressure with the mother's thighs flexed over the abdomen. That's very diagrammatic here. If the baby is still not delivered, consider giving an episiotomy, or if you have already given episiotomy, consider extending the episiotomy. If still not delivered, you can do either of the two things. Delivery of posterior arm, you can put your hand inside the sacrum, inside the pelvis over the sacrum, you can grasp the posterior arm and remove it. Once you remove the posterior arm, the diameter of the shoulder decreases. That's one method. The other thing is, the other thing is interior rotation, internal rotation. You can rotate the shoulder. Now, if this is your pelvic inlet, the shoulder is dislodged. So the shoulder is lodged in this plane. What I will do is, or the shoulder is, sorry, that's incorrect. This is your pelvis and the shoulder is dislodged, lodged in this anteroposterior diameter, which is the shortest diameter. What I'll do is, I'll hold the shoulders of the baby, one shoulder or both of them, and I'll rotate it a little. You can rotate it by 1/8 of a circle to bring it in this plane, oblique plane, which is a little larger than the AP plane, and you can deliver it easily. If this doesn't happen, what we do it, we rotate it by 180 degrees. While rotating it by 180 degrees, with the help of screwing movement, one shoulder comes below the other shoulder and it becomes easier to deliver the baby. So that is internal rotation. It can be by 1/8 of a circle or by complete 180 degrees. If it doesn't deliver by rotating it to 1/8 of a circle, then you go to rotating it to complete 180 degrees. If even after this rotation and trying to deliver the posterior arm, even after all these things, if your baby has not delivered, then what you do is you replace the head into the vagina. Whatever the head has come out, the shoulder is not coming out. Now I have to take off a section because the baby is not delivering. So I'll put the head. Now to do this section at this stage, this is the abdomen, the head is outside, the shoulder is inside. To deliver this baby by cesarean is also very difficult. So you have to place the head, rotate the head and place the head back in the vagina and push it as high it can go and then take the patient for section. So this rotating the head and pushing it in the vagina is called Zavanelli maneuver. Right, so this is the algorithm for managing shoulder dystocia. So your answer here is flex mother's thighs. McRoberts maneuver is flexing mother's thighs. Okay, the answer here I have written here is incorrect. It is B, flex mother's thighs. Surfactant. Now I could not get the other options for this question because most of the students thought that this was a very easy question and a straightforward question. So if this was the option and there were no other eligible options, this is going to be answer. Surfactant formation is stimulated by corticosteroids. Dexamethasone is one of them. Surfactant is formed in type 2 pneumocytes in the lung which line the alveoli. A course of corticosteroids is given in preterms to accelerate formation of surfactant, and this helps in decreasing the chances of respiratory distress syndrome for surfactant from surfactant deficiency. Now there was a diagram which was similar to this one, uniconnuate uterus. This is a straightforward question. The answer is uniconnuate uterus only if the option was not pseudo-uniconnuate uterus. Now pseudo-uniconnuate uterus is a condition in which there are uterine adhesions. So that one half of the uterus is completely obliterated because of adhesions, and you see on HSG only one half of the uterus. So this also might look like uniconnuate uterus. That's why it's called pseudo-uniconnuate uterus, and it is seen in TB. Since the options here were only uniconnuate uterus and the other options were not compatible, your answer here is uniconnuate uterus. Uniconnuate is single con is there, the other is not present. Unilateral agenesis of Mullerian ducts is uniconnuate uterus. Then there was this question with 4 images in series. They asked you what kind of picture this is, if it is MRI or CT. This is straight away, this is clear-cut hysterosalpingography. What we do in hysterosalpingography is we take picture in 4 phases. First phase is you inject dye. Hysterosalpingography is a contrast radiation, X-ray imaging. What we do is we insert dye inside the uterus. First phase is supposed to fill only the uterus. So in the first picture you will see the uterus only. Now this is not a very good picture. The uterus has not been anteverted properly. Now this is a better picture. Here you should have got a proper image of uterus without the tubes. That's first image. Second image, you push a little more dye. The dye spreads into the tube. So you see you delineate the tubes. Here you can see the tubes. That's second phase. Third phase is, this is not proper. Third phase is the dye spreads into the pelvis. Now see this leaking of dye into the pelvis. This indicates that tubes are patent. That's the whole idea of having a hysterosalpingogram. Sonosalpingography is similar. Instead of X-ray, you use ultrasonography, and instead of a radio opaque dye, you use saline. What I do is I slowly, with the same procedure, I will inject dye, and at the same time I will do ultrasonography. The pictures obtained will be completely opposite. In ultrasonography, clear liquids appear black. Hypoechoic we call them. So this, if it is white, remember it is radio opaque, that is X-ray. This is X-ray. If the dye appears white, it is X-ray. If the fluid appears black, it is ultrasonography. So if I change this image to black inside, if I change this image to black inside and echogenic or ground glass appearance of USG like features, then it becomes sonosalpingography. The principles are same. High risk pregnancy includes all except, now the options, if these were the options, here I would mark previous manual removal of placenta, because obesity is indication of high risk pregnancy. Anemia and preeclampsia definitely are high risk conditions. Now according to the all the data that I collected, I could come up with this. There are certain high risk conditions. Her high risk conditions can be pre-pregnancy. Before the pregnancy itself, she is a high risk patient. These conditions would be, she is a patient of high blood pressure, diabetes, HIV positive, overweight or obese, or she is pregnant with multiple fetuses, she is very young or older than 35 years of age. These are high risk pregnancies. While previous manual removal of placenta does not indicate that she is going to have manual removal of placenta again in this pregnancy, or she is going to have any high risk, unless this manual removal of placenta was associated with infection or adhesions. Apart from that, only a history of previous manual removal of placenta is not high risk. High risk is usually a medical condition which is already present in the mother, or it may develop in the course of pregnancy. As she progresses through the pregnancy, she develops anemia or preeclampsia. So high risk conditions can be pre-existing or can develop during pregnancy. A history of manual removal of placenta definitely is not high risk pregnancy. Or rather, compared to these things, this is the most eligible option here. The last question, very important. There was a recent change in the NACO guidelines regarding management of HIV in pregnancy. Now, the guideline says at whatever period of gestation, be it the first trimester or 36 weeks or after delivery, once you find a pregnant patient who is HIV positive, you are going to start ART, the recommended ART regime which is given. You are going to start ART at that time only, and you are going to continue ART lifelong in this patient. Not just for the pregnancy or 6 weeks or after breastfeeding. All those things have been changed and it is lifelong. They say the principle is, once a female has conceived, she is in the reproductive age group, she is going to conceive again. So to cover that pregnancy and to cover further any pregnancies, we want the female to have ART lifelong. Apart from that, this will also affect her health. She will be healthier, free from AIDS if you start ART and give it lifelong. The principles of management according to the latest NACO guidelines are start ART as soon as possible. So you have diagnosed at 6 weeks, you are going to start ART at 6 weeks itself. Continue throughout pregnancy, delivery, breastfeeding, and thereafter lifelong. So once a patient conceives in India who is HIV positive, she becomes eligible for ART lifelong. That's the latest modification or latest update of NACO. Even if she presents at 36 weeks, you are going to start the same ART. The regime that is used is tenofovir 300 mg, lamivudine 300 mg fixed dose, and efavirenz 600 mg once a day. Efavirenz has to be taken in empty stomach preferably. The other approved regimes are these. Lifelong ART, they advocate lifelong ART because this will keep the woman alive and it will improve her own health. Avoid stopping and starting. Now this, since she is in reproductive age group, she is going to conceive, definitely going to conceive again. So you don't want to be stopping and starting again. This will increase drug resistance. So in reproductive age women, once we start ART, we are going to continue ART lifelong, providing early protection against mother to child. In the next pregnancies, the protection to the fetus will be more, it will be earlier, and drug resistance by stopping and starting drug will be avoided. This is the list of references for all the questions. The last question I have not mentioned this, the reference is NACO guidelines, the latest guidelines. It is available freely on the internet. Thank you very much.